heading for the finish line now, and we have a topic that may be of special interest to certain baby boomers if they were among that crowd. I wouldn't know because I wasn't one, am not one, but our next speakers, there are two. Dr. Jeffrey Leimbacher practices medicine in Largo and is board certified in both family practice and emergency medicine. In addition, he's associated with the Medical Marijuana Treatment Clinics of Florida, a network of 10 clinics that support the public's safe access to medical marijuana through the Florida Compassionate Care Act. And joining him in this presentation is Dr. Cameron Vance, who is CIO of PharmD. Dr. Vance is a pharmacist, member of the American Pharmacists Association and the American Academy of Anti-Aging Medicine. He has diverse experiences in the fields of community, compounding, veterans, psychiatric, and hospital pharmacology. His professional interests are medicinal, cannabis, pain management, neurology, and endocrinology. Please welcome Dr. Jeffrey Leimbacher and Dr. Cameron Vance.
Hi, I'm Dr. Jeff Leimbacher, and I run our local medical marijuana clinic through MMTC. Cameron Vance is part of our founders of the clinic, and he's going to give a presentation, and I'll be available afterwards for some questions and answers. But let me give it to Cameron Vance.
Hi, good afternoon, everybody. Exciting topic this afternoon, for sure. I'm very excited for the opportunity to be here to meet with you all to discuss medical marijuana and what it means today, what it is, how does it work, why does it work, how do you become certified to be a patient for medical marijuana in the state of Florida, where do caregivers fall into the process? A lot of questions that come up daily in our clinics, and when I got started in this industry, I had a lot of questions myself, even as a pharmacist learning about medical marijuana. So during this session, I hope that I'm able to answer many of the questions that you may have about medical marijuana, and I'll be available at the very end as well to meet you over at the table with Dr. Jeffrey Leimbacher to discuss any further details you want about any of the topics. So, to provide you a little bit of background about myself and how I got involved in patient care and alternative health care has truly been through my experiences as a pharmacist. As a pharmacist, I've had the opportunity to work in a lot of different settings. I've worked in retail pharmacy, that's your Walgreens, your Rite Aids, we are all aware of those. I've had the opportunity to work in hospitals, both large scale and small scale in rural communities. I've worked with veterans in the VA, inpatient psychiatric hospital, even did a small time with a nuclear pharmacy. And what those different settings did is it gave me the opportunity to meet with a lot of different patients from a lot of very diverse backgrounds. Patients suffering from Alzheimer's disease, Parkinson's disease, cancer, epilepsy, post-traumatic stress disorder, cancer, just to name a few. And my goal as a pharmacist has always been to help patients do well, to help them make an informed decision about their health care. We're in a very unique position where we can, to some degree, kind of cut through the fluff to help a patient make an informed decision about their care. And what I would find in my experiences with these patients is, quite frankly, that many did well on Western-type medication, big pharma medications, traditional therapy. But I also found that, many patients unfortunately did not do so well. And some patients that did okay, I really felt they could have really stood to do a lot better. At the end of the day, your health is everything, right? If you don't feel well, most oftentimes you don't do well. I began to get involved in alternative medicine. I got involved in an industry of compounding pharmacy where I was able to work with patients that didn't fit the one-size-fits-most mold. I was able to make primarily different capsules. A lot of these were filled with different combinations of antibiotics, respiratory treatments, different syrups, different suspensions. And what was really amazing to me during that time is that these patients really did well. They responded to these, non-traditional types of therapies. And I sat there just like you at one point, watching this movement of medical marijuana and cannabis go through our country, right? Oregon, medical marijuana laws, California, Colorado, we've all seen it in the news. And then it came to Florida. It wasn't long after Florida, Texas, Puerto Rico, my home state of West Virginia. I wanted to know more about it. As I reflected on my interactions with patients over time, often patients would come to me and say, Cameron, I use marijuana. As they got more comfortable, nobody typically runs right out and says it, right? But I would hear it from time to time because they trusted me. They wanted to know what I thought about it. And I'll be honest with you, in the very beginning, I didn't know much about it. I wasn't taught much about marijuana, medical cannabis, in pharmacy school. Many physicians I meet with daily, they weren't taught about it in school. I was taught about marijuana, yes. Most of the time it was something along the lines of drugs are bad, right? Unless, they're prescription drugs, which is kind of interesting to me. I had a lot to learn, and I wanted to know more. I was very naive, like I mentioned, in my knowledge as I got started. A question I had for myself that maybe you all had, it's embarrassing sometimes as a healthcare professional, but when it came to using marijuana in the beginning, I truly thought it was black and white. You got high or you didn't get high. And if you didn't get high, you're clearly using it wrong, right? I had a lot to learn. That's the furthest thing from the truth. So working with my patients over time, I wanted them to be informed about their healthcare decision, what might be best for them as an individual. And I would think about things in my mind as I sat there about what I felt about medical marijuana or being able to represent it to my patients, right? I grew up north in West Virginia, and what I saw there was a lot of poverty, a lot of broken homes, a lot of destruction. What happened up there, which we all know down here as the opioid epidemic, right? When I relocated to Florida, I found it wasn't much different, if not worse. There's this pipeline right up the Appalachian Trail. They're making a movie about it called American Pain, and it was concerning. I would think about cannabis. Is it a gateway drug, right? It's a fair question. Everybody's thought about it. You'll certainly read articles about that it can be a gateway drug. And in the articles, you'll find representation that, to some degree, that is true. What you'll find in the research is that individuals that use heroin and cocaine are more likely to have used marijuana previously. But what's much, much more true than that, where the direct correlation is that the individuals using heroin and cocaine were much, much more likely to have started with alcohol and cigarettes, and those same patients, it was at a much, much younger age, early entry, well below the legal age. I would think about things like dependency, These opioids, opioid epidemic that we went through, this is the Lortabs, the Vicodin, the Percocets, the fentanyl. When you look at dependency, science is beginning to show us that dependency related to the medical use of cannabis is more or less right in line with that of caffeine. But these opioids that have ravaged our country, dependency is over 3 times higher. which is a major concern. When I was learning more about medical marijuana and the applications to try to help my patients become better educated several years back, I came across this U.S. patent. I thought maybe you've seen this before, maybe not. It's this U.S. patent 6630507, which I found to be interesting. What it is, it's the federal government's patent on the intellectual property for the use of marijuana to protect the brain from neurodegeneration. While at the same time, the government classifies marijuana as a Schedule I drug. That means no medical use. It felt a little unfair to me. It didn't quite add up. I understand that things aren't simply as black and white as this, but seemed a bit hypocritical, something to begin to think about. As a Schedule I, where marijuana is, that's regulated more tough, more regulated than Vicodins, the Percocets, the Oxycontins. Those are a Schedule II. Even cocaine is a Schedule II. I would begin to think to myself, what does a medical marijuana patient look like, right? We all have these ideas. Well, Snoop Dogg and Willie Nelson, right? Of course. I mean, they're clearly using marijuana in the pictures behind me. Medical marijuana, I'm not so sure. They're both going on very strong right now, but let me tell you what I found through our clinics, and in St. Pete is our closest clinic, what a medical marijuana patient looks like here in Florida. It's the blue-collar worker. It's the IT professional. It's the lawyer. We have several medical doctors that are patients, nurses. We have more employees of the state than any other industry type. Average age of our patient, 53 and a half. Male to female ratio, almost exactly 1-to-1. It's a lot of patients looking to do better, looking to feel better, looking for alternatives. One of the dispensaries is here in the back. I recommend you meet with them today. Their name's Afria, and they have some of the different types of products that can be seen at local dispensaries. They see more patients than we see, and I think you'll hear it's a lot of friendly, smiling faces, a lot of people looking to do better that look more or less a lot like you and I. So whenever Amendment 2 was passed, you guys are probably familiar with this. This was last November 2016. What this law did was it expanded the conditions that a patient may qualify for medical marijuana in Florida under. And I want to go over that here because it's very important. Patients that can qualify for medical marijuana in Florida, well, I understand you can read, is cancer, it's epilepsy, glaucoma, post-traumatic stress disorder, ALS, that's Lou Gehrig's disease, Crohn's disease, Parkinson's disease, multiple sclerosis, a terminal condition, or they put a caveat at the end. And the caveat is where I think the state really got it right. It's where they stayed out of the way of the decision between the patient and their doctor. And it reads as such: or another debilitating condition of the same kind or class as, or comparable to the conditions listed above. We treat lots of patients in our clinics suffering from anxiety disorders. If you think about that, post-traumatic stress disorder, PTSD, a lot of those patients suffer from anxiety, right? Anxiety is a comparable condition to PTSD. We have lots of patients with migraine disorders. It's a neurological disorder. We have very interesting cases of Lyme's disease. We see, of course, patients suffering from muscle spasms, ulcerative colitis, degenerative disc disease, just to name a few. But if you want to begin to understand medical marijuana from an elevator view and how does it work, how does it treat so many things, you have to start by understanding a little bit about the endocannabinoid system. So if I could get a raise of hands, has anybody in here heard about the endocannabinoid system before? Several hands in the back, a few up front. That's fantastic. You guys are ahead of the game. It was not taught in pharmacy school. And getting the knowledge that you have today is very important. What it does is patients begin to, or prospective patients begin to ask their doctors the hard questions about medical marijuana, the endocannabinoid system, and how it works. What we're seeing is medical schools are beginning to put this into their curriculum and doctors are becoming better educated about it. So all of us in this room, whether we like it or not, we have an endocannabinoid system. Just like we have a cardiovascular system in our body. Some of us may have had a bout with high blood pressure, an elevated heart rate, cardiovascular system, right? These patients might take a medication like a beta blocker, for example, metoprolol, atenolol. Those are just a few of them. And what that type of medication is used for is to help decrease blood pressure and at times heart rate. We have a respiratory system, right? We've all probably seen someone use an inhaler at one point in our life. Most commonly, we see albuterol, different brand names, ProAir. And what that medication does is it stimulates, it's called a beta-2 cell, it's a beta agonist, to when the patient gets chest tightness, it restores that, it dilates it, it builds back that homeostasis. The endocannabinoid system is where medical marijuana in and of itself works, where it does its actions. Science has shown us that 90% of disease states have an imbalance in the endocannabinoid system. Being able to restore that balance gives a shift to help patients do well. A lot of doctors and myself like to look at the endocannabinoid system and the use of medical marijuana to treat or work with it is in a way that it mitigates, I guess you could say, a nutritional deficiency, restores that homeostasis. So from an elevator view, if you want to get an idea of, how the endocannabinoid system works, I'll make it real easy for you, specifically in pain. There's 3 things to think about. Number 1 is a receptor, okay? Number 2 is something that binds to a receptor. And number 3 is something that breaks apart that bond. Simple as that. Receptor, something that binds, and something that removes it apart. Behind me, up top, you'll see green. That's a CB1 receptor, and in blue is a CB2 receptor. These are the receptors in our body doing work right now, with or without cannabis, that we know the most about. CB1 receptors are primarily identified in the brain and spinal cord. They're also found in the GI tract, in the liver. CB2 receptors are primarily thought to be involved in the immune system. We find them in the tonsils, for example, in the spleen, the blood cells. The middle part there is AEA. That's just an acronym for anandamide, and 2AG below. This is the part that binds to the receptors. They're really cool in the situation of pain, I think. It bores my wife, but they're identified as the bliss molecule. So as we sit in our seats, if we begin to have a little bit of pain or an ailment, AEA is released into the body, and it helps calm that firing. They're created on demand. At the end, you'll see that part that breaks apart that bond. That's called FAAH and MAGL. So receptor, something that binds to the receptor, and an enzyme that breaks apart that bond. What's really neat in research today, out in the fields, even in the big pharma companies, they're looking for ways that we can replicate and reproduce AEA and 2AG. They're looking at ways, well, what if we can make that bind last longer? What can we do? Science has shown us by accident early on what happens if you dysregulate and how important that system, those receptors are. There was a drug that came out on the market a while back. It was a diet drug, a weight loss drug. It was called Vance. They got this idea that, well, we've heard about cannabis and the munchies, right? What if we block that CB1 receptor that you know about? Maybe we can decrease hunger in those patients. Well, unfortunately, what they found whenever they put that type molecule in the body is that these types of patients all of a sudden had a major increase in depression, anxiety, by manipulating it, by blocking it. Suicide rate on patients using that drug went up. They immediately pulled it off the market. We all have an endocannabinoid system. It's important that we keep it churning at homeostasis at a normal level. Another item that's really cool about it is that, for example, patients with fibromyalgia, right? They have a lot of painful disorders. We maybe don't necessarily know what it's coming from. This applies to Crohn's disease as well. What we found in science is that a lot of these patients, They don't have as many CB1 and CB2 receptors that maybe you and I have. They have a lower threshold. They don't have as much anandamide and 2-AG. What cannabis does is it increases those number of receptors. It restores the balance, brings back the homeostasis to make things function again. You see all these disease states. These are just a few that we've been able to treat with cannabis. If you're anything like me, over time you become a little bit skeptical of cure-alls, fads, things along those lines. I certainly am. I've been burned before. It's usually in the diet world, a new berry will come out and people start calling me, what about this new berry? Well, it's helped me save a bunch of weight, and then all of a sudden, boop, sorry, it all of a sudden causes liver damage, So if you're anything like me, you start to think to yourself, Cam, you're telling me I can take cannabis and it can calm seizures in the brain, all this abnormal hyperfiring, but it can also help with all this inflammation in the GI tract and then the gut. Is this like the Swiss Army knife of medication? And I got stuck there, honestly, in the beginning, even as a pharmacist. I had that same question, and I hear that question a lot. This is really what it comes down to with cannabis, okay? When you think about the drug Tylenol, right? We're most familiar with Tylenol or ibuprofen. At the end of the day, as good as Tylenol is, or as bad as Tylenol is Tylenol. It's one chemical, okay? Cannabis is a combination of over 480 identified chemicals that work in the body. Many of these are called, a fancy name, cannabinoids. These are things like THC we've probably heard of, but a whole host of other ones, in addition to what things called terpenes, I'll discuss that in a moment, and flavonoids. What makes cannabis work so well is what we identify as the entourage effect. No chemical by itself does as great as a combination of the chemicals working together in the right concentration for the individual patient. Some patients will do better with THC and CBD. Some patients will do better with more THC. Some patients will do better with more of the other chemicals. It's this harmony, and when you find the right harmony, we're finding patients doing quite well. Anybody in the room ever use aromatherapy by chance at home? A lot of people in the room. Okay, so my wife loves aromatherapy. We use lavender. Anyone use lavender? Almost all of us. Okay, great. So lavender works great. We continue to use it. It helps with calming, right? Brings down anxiety, helps us sleep a little bit. Lavender is a chemical called beta-myrcene, okay? Beta-myrcene is a component of the cannabis plant. These are called terpenes. They're not just in cannabis, they're in our everyday life. There's other ones called limonene. There's linalool, that comes from hops, which is used to make beer. Different strains have different combinations, and patients being able to find that right combination and harmony gives the different disease states a better balance. Patients with low receptors are able to restore that. Patients with difficulty sleeping might pick something that's higher in lavender or beta-myrcene and linalool to help with sleep, while somebody without that trouble would pick something on the other scale. I have these wheels back on our table. I'd be happy to show them to you. It's just a little bit more information about some of the 480 known identified chemicals that are in the cannabis plant and where they provide some different value. A lot of people hear THC, and are familiar with that, but it's just quite one small part of the puzzle. CBD, which is the bigger part, is a non-euphoric part of cannabis that patients respond really, really well to. I won't have you raise your hands for this slide, but if you've ever had the chance to look at a cannabis plant, I see a couple hands, you may have noticed little white crystals on the top of the plant. The dispensaries will grow them this way. And under magnification, you'll see that little waxy ball. I think it's really neat. It's called a trichome. And for the most part, that's where our medication comes from, in that waxy ball or residue. This is what the dispensaries that you're hearing about in Florida spend millions of dollars on equipment to be able to extract it. off the leaf of the plant to be able to make your final formulation or your cannabis medication. Anybody heard by chance of the gentleman on the bottom? His name's Raphael Mechoulam. I'd like to meet this guy one day. He's considered the grandfather of modern cannabis research, okay? He is given credit for understanding and characterizing the endocannabinoid system. That's the receptors, the binding, the breaking apart that you all now understand. He's done a lot of his research over in Israel. That's really, truly the hotbed of research. But in addition to that, we have a lot of research in Canada. We have a lot of research in Spain. We have a lot of research going on in the United States. Ole Miss is beginning to do a lot of federal research. The National Institute of Health the U.S. government has funded research in Israel. And we're even beginning to do research right here in Florida. There's some hemp projects going on. There's studies being done with patient data at Moffitt. It goes on. But what you'll begin to hear, and what you've probably heard before, is that there is no research. We can't use medical marijuana. We don't know anything about it. There's not enough information out there. The deputy director of Normel, if you're familiar with that, I see some shaking heads, I think he best characterized it that there's often pushed that there's no information available, that we should immediately discount cannabis and its actions. If you're a nurse, a pharmacist, a healthcare provider, a caregiver, an interested patron, there's a database online where you can go and look at the latest and greatest articles about anything you like, any disease state, research on different topics. They're peer-reviewed journal articles and studies that are published. It's called PubMed. PubMed.gov is where you can access many of these. What I find interesting when you hear all the time in the media that there's no studies, if you were to type in the word marijuana in the search bar, you would pull back 25,510 peer-reviewed articles and or studies. At the same time, if you type in hydrocodone, that's the opioid, Vicodin, Percocet, fentanyl, you pull back 960. You type in Adderall, that's an amphetamine that we give our child, a stimulant for ADD, ADHD, you find 201. I'm not saying those drugs don't have their place, but all of a sudden that seems to be okay. There's a lot of research available out there, and I would argue and agree that we need a lot more research. We're talking about 480 chemicals to learn about, plus disease states. But you have to accept, to some degree, that we have a really good place to start. The CDC, as we all know, if we've talked about earlier, has indicated that the United States is still in the midst of an opioid epidemic, death from the Vicodins, the Percocets. On the chart, this is data from 2015. There were 33,000 deaths or overdoses associated with the use of opioids. 18,000 were from prescription opioids written by a doctor. 2016 data just came out recently. 53 Americans die every single day from prescription opioid, Percocet, Lortab, overdose. I put the slide up here just to kind of give you chuckles. It's more of a serious matter than that. Deaths from selfies in 2015-12, cannabis 0. But there was this publication put out in 2016 about the health and social effects of non-medical use of cannabis. This is very important. The WHO, the World Health Organization, they study pandemics, epidemics. They study global disease states and put together research. They indicated that there are no reported fatal overdoses in the literature related to cannabis. That means there's been no deaths from overdose associated with cannabis in the world. You can overdose from water, truly, and become hyponatremic. What that all boils down to, essentially, is that there's very limited number of CB1 receptors that you know about in the brainstem. That's the part that controls respiration. That gives cannabis a very encouraging, safe profile. Are there deaths associated with cannabis? I'm sure of it. People abusing, potentially, getting behind a car, something along those lines. But from overdose, 0 in the world. I was asked to talk a little bit about Parkinson's disease. It's something that affects many of us, several of us, I'm sure, in the room. In America, 60,000 Americans are diagnosed every year with Parkinson's disease. We have 1 million Americans suffering with Parkinson's disease today. As we all know, it's a progressive disorder that affects the neurons in the brain. It can go on to impede muscle movement. We have a lot of patients that come through our clinics suffering from Parkinson's disease. And I reached out to several of our doctors to find out some of their experiences with these individual patients. I had one patient personally that I worked with to get their dose to the appropriate level. And this patient started, had the tremors, difficulty sleeping, to name a few, and we started them out on a course of therapy. And after about 2-3 weeks, the patient's wife called in. She was the caregiver and said, you know, he's not really doing that much better. They wanted to start on what's a non-euphoric, no THC type dose. So we did that. The studies show us that these patients do best from a combination of low dose of what's called CBD and THC together. And after a few weeks, he wasn't doing well. She called in and said, hey, you know, maybe I'll take your advice. We can do a little bit of the THC. That's what science shows us, shows value in these patients. And let's get going. After about 2 months, the wife called me in tears, which really keeps me going. She said, Cameron, my husband was able to drink a cup of coffee for the first time today without the fear of spilling it on himself. That's a really big deal to some people. It's a really big deal to all of us. That's not the result we see in every patient, not at all. But when we talk to the patients that we've been working with over the last year and a half that have Parkinson's disease, we hear most frequently that it has definitely improved their quality of life. We hear oftentimes some of the rigidity is improved. We definitely hear help with sleeping from these different patients. With cannabis and Parkinson's disease, it takes an average of 1.7 months to get a positive result if we're going to have one with regards to the tremor aspect. Studies show that 3 months or more of continuous treatment is more the goal we need to be at to get any relief there. But we have a lot of patients' improvement with pain, tremors, and sleep. Alzheimer's disease, as we all know, is a progressive disorder that affects our memory. It's a combination of neuronal death, it's a type of dementia, a buildup of what we know as plaques and tangles that inhibit the normal smooth transaction of information processes in our brain. With these patients, we're seeing a lot of improvements, first and foremost in appetite. Caregivers report a lot of improvement in agitation, anxiety. Again, quality of life has been much improved. There's a whole host of mechanisms, I won't go into that here, about how cannabis works, but science is showing great advances in that. Could cannabis help us get the most out of our retirement? I think this is an interesting topic. You know, there was a study published by Johns Hopkins and Temple University that came out back in January of 2017. And what they did there is they went and they looked at states that had medical marijuana laws in the books where patients could have access to medical marijuana, and they wanted to look at the productivity of those 50 and above. What they found from this study is that patients had a 9.4% increase in the probability of employment. This was slightly higher if you read the study in males and females, and 4.6 to 4.9% increase in hours worked. Well, I'm not saying that once you retire, you want to go back to work or anything along those lines, but as you begin to read the trial, what you begin to see is that these patients began to feel better. They were getting their life back. They started to do better again, which is, I think, quite powerful. So where are we today with regards to medical marijuana? I think we're in a really cool place. It's no longer just the flower, that we've grown up maybe to know. It's standardized, normalized dosage forms. And what that is doing is it's becoming more acceptable to healthcare providers, more acceptable to patients. You'll see samples in the back of, they're inactive samples, I'm sure, of different types of products you would see if you went to a dispensary. We have sublingual drops that you put under your tongue. Patients do great with that. There's sprays, capsules. There's vape pens. Topical creams. We have a patient with osteoarthritis in our clinic. She called me, Cam, I'm doing amazing now. I just want to tell you the story. Okay, what's going on? I started using the topical. I no longer use my icy hot. I now use my icy pot. I was like, okay, this is clever. Can I borrow that? And she lended that to me, so I wanted to share that. There's also patches now coming out, and they all have their place in therapy. What's really cool now is that patients are able to individually determine what the appropriate dose is for them as an individual. Everybody's a little bit different. I have patients that come to me all the time. They'll say, Cameron, I'm doing great using marijuana. I now want to go to kind of more the legal route. I smoke 2 joints a day. What is my dose, right? I wish I could tell you. I'm like, well, who was your dealer? Was he... I have a really good idea of what he was probably using just by doing math, but what's really cool now is you know exactly what your dose is going to be by slowly titrating to effective dose. It's really cool. And the dispensaries are held accountable by the state that what's in their bottle has to be exactly what they say it is. They have to do pesticide testing to make sure no microbials are within the product, and most all of them are pesticide-free. They grow organic. So how do I become a patient today in Florida? It's really 4 easy steps. Number 1 is you schedule an appointment with a doctor. We have a doctor in town. You met him. He's amazing, Dr. Jeffrey Leimbacher. He works in the St. Pete Clinic. He's really a pioneer in the industry. He's been there really since the beginning. You schedule an appointment with the clinic. What's an appointment like? You essentially sit down with the physician and you discuss what's going on in your life, and he'll go over treatment options with you. If you qualify, it's a risk-free assessment. He gives you an ID number, and what you do is you apply for a card from the state. It looks like a driver's license. Once you get your driver's license looking ID back from the state, you can go into a dispensary. There's more in Tampa than anywhere else in the state right now. Or they'll home deliver to you, most of them for free, to receive the product that's been ordered for you that you discussed with your doctor. And then we do a follow-up appointment as required by law after 7 months, between the 6 and 7 month mark. What we do is we assess that information, we document how you're doing, make tweaks if necessary, and a lot of that information is gathered and submitted for research to help other patients. So what about caregivers? Where do they come in? Caregivers are a huge part of cannabis. The law put into place legal routes for caregivers to be involved in care for patients. The rules, some of them are you have to be 21 or older. For the most part, with regards to caregivers, it's 1 caregiver per patient. There are exceptions, like a caregiver of a child 18 and under if there's multiple siblings being treated, or a caregiver licensed working in hospice. But a caregiver, as long as they're a legal guardian by court authorization or have the power of attorney that we've talked about a few times today, they can apply next to the patient, mail in for their own identification card to assist the patient with their medical marijuana needs. So what that does essentially, once a caregiver gets a card approved by the state, it allows the caregiver to go into the dispensary and purchase the product on behalf of the patient to help out with that. What I see more oftentimes than not is delivery is so available within Florida, the caregiver will set up delivery. They don't necessarily always go through that caregiver card process, but they'll just be at home when the delivery is scheduled to arrive to help with the transition of the medication being delivered from the dispensary. Very, very easy stuff. So common questions that I receive all the time that I thought we would go over here. I get the question, I'm nervous about using cannabis. I don't want to get a euphoria. I don't want to get high, okay? If that's something that's going on in your mind today, you are in the majority. Only 10% of patients have any goal of having any form of euphoria whatsoever. Some patients with very severe debilitating cancer along those lines, maybe they need some more relief there, okay? A lot of patients get scared about using a little bit of THC because they're afraid of a euphoria. Well, we're big believers in low dosing, starting low and going slow, and titrating the dose to effect. Just because you have a little bit of THC in your formulation doesn't mean you get a euphoria. Just because you have a sip of wine doesn't mean you get drunk, unless you're my wife. But it's all about effective dosing. And by going slow with the process, which is the hardest thing to teach, and it's a tip I'll give you because it'll save you a lot of money, is starting at a low dose. What I'm saying is around, and we'll go over that in the clinics, around 5 milligrams of a combination, and then gradually increasing it over 2 weeks. What your body does is it starts to turn on more of those receptors you now know about. It starts to turn on more of that AEA, that anandamide. So your body starts working for itself. If all of a sudden we give ourselves a bunch, yes, it'll probably help quickly. Your body says, whoa, I'm already producing all this, and stops producing its own. If you make a mistake, it's typically guys in my experience, they try to triple and double everything. What's great with cannabis is you can take a weekend off in most situations and it will reset that for you. But it's all about starting low and going slow. How soon should I see results? Really depends on the situation, depends on the patient. Something like sleep, pain, a lot of times it can be pretty quick. It can be that night, it can be within a couple weeks. Parkinson's, like I talked about, can take a couple months if you're going to see results for tremors. Common adverse effects, dizziness, the standard type adverse effects that we read when we open our Walgreens label about any medication we get. Some people want the drowsiness. They buy that higher terpene content with the lavender. Others don't. For the most part, at normal medical doses, we're really not seeing much. You see those commercials out there all the time. It's, spouting off all these adverse effects. At the end, more now than not, I see may cause death. If I've showed you anything, you can't overdose on the use of cannabis. Jeffrey Leimbacher is happy to answer questions for you this afternoon. He'll be in the back at the table. He's coming up now. We're happy to help with you as friends, as colleagues. It's a photo of our clinic here locally. Just the conditions again for you. Thank you all for your time. I really appreciate it. Thank you.
So, if I may add just a few comments. I retired from the emergency room about a year ago, and I got kind of bored, was looking for something to do, and somehow through connections I got hooked up with these guys, and I sort of started as a lark. I was just kind of out of boredom. And then I started seeing patients, and it's been about a year now, so I'm seeing patients coming back with their 6-month checkups. And I have to tell you that there's a medical aspect of this business, there's a business aspect of it, and what's interesting, there's a political aspect of it too. I'm not on Jeff Sessions' Christmas card list, I don't think. But I'm seeing patients coming back for their 6-month checkups, and the stuff does work. And I'm talking about people who never smoked marijuana before. As an ER doctor, I can't tell you how many young kids I saw overdose and die on opiates. And yet here we have a drug that you cannot overdose on. It's so good for chronic pain and for other entities. And I think we have about 70% of our patients are coming back, and the other 30%, I think we call, and it's not so much, I think it's probably more financial reasons they don't come back than it's not working. But the one thing that and Cameron alluded to this and spoke about this, it can take a while for someone to get the proper dosing. There's not one size fits all. I always give the example, if you have strep throat, I can write 500 milligrams of penicillin 4 times a day for 10 days, and that's the right dose. With medical marijuana, everyone's different. Depends on their functionality and what they're doing. We have a lot of people who work. And Cameron also said most patients, they want to take something low in THC and high in CBD because they really don't want to be incapacitated. They don't want to be high. And it really does work. And I've become sort of passionate about it now. I really enjoy what I'm doing. I enjoy seeing the patients. And we have doctors, we have lawyers, we have teachers, we have nurses. And I'd say most of the patients, and like Cameron said, they really don't want to get high. And anyways, I encourage you to, if you have any questions, come back and talk with us there, and we'll be happy to answer them for you. Okay?